Hello friends, welcome back to this channel. So today we will learn about the tachyarrhythmias. Before starting this tachydysarrhythmias, I strongly recommend you to watch the previous video where I have explained the classification of tachyarrhythmias and I have cleared few confusion that usually occurs in students. With the reference of this previous video, it will be very easy to understand and process this upcoming video sessions. So first of all, in this video, we will start with the supraventricular tachycardias. So supraventricular tachycardia comprise of atrial tachycardia, then atrial flutter, fibrillation, then PSVT, then AVRT. So these are the supraventricular tachycardias, and we will learn one by one and we'll see the basic ECG changes in it. First, we will start with the PSVT, paroxysmal supraventricular tachycardia. It also called as AVRT, that is Atrioventricular nodal re-entrant tachycardia. Okay, so let's start with the mechanism behind the formation of PSVT and how it creates chaos in the body. The first one is mechanism. To understand the mechanism of PSVT, I would like to revise first the normal pathway. So normal pathway starts with the SA node, then AV node, then bundle of his to right Purkinje fiber and left Purkinje fiber. Now this AV node, if you magnify this AV node in the heart, you will find that AV node consisting of two pathways. The first one is slow pathway and the second one is fast pathway. Let's assume this is slow pathway and this is our fast pathway. So what is the basic difference between these two pathways? The fast pathway, the conduction is fast, but refractive period is long. What about the slow pathway? Its conduction is slow, but the refractive period is short. So slow for short and fast for long, right? So in normal individual, SL node will give the impulse to the AV node, and in AV node it will give impulse to fast fiber and slow fiber as well. Now at this point both the fiber meets, okay, and they will go to bundle of his and then right and left. When SL node transfer its impulse to slow and fast, the fast pathway reaches this point early, so this slow pathway gets diluted. So there is no as such significance in normal conduction. Fast pathway will reach here early and slow will get diluted. So this is the basic natural thing that is happening in the body. Let's understand what exactly happens in the PSVT. So PSVT starts with premature atrial beat. So this will give to SA node, this will give to AV node, and from AV node it will travel to bundle of his and right and left one. Whenever there is a premature atrial beat, the SA node has given one impulse already, but in meanwhile premature atrial beat will also arise in SA node. Now SA node will give impulse to AV node. AV node has two pathway, one is short, one is fast. So this is, suppose this is the fast pathway and suppose this is the slow pathway. Now since its refractory period is long and its refractory period is short, this impulse will travel through slow pathway, because at this point of time this pathway is in refractory period. Understand? So premature atrial beat will give impulse to the SA node and SA node will travel the impulse to AV node, and in AV node at that particular time of point the fast pathway has become a refractory and slow pathway is receiving the impulse, right? I will write it down. By the time it reaches, it means impulse at lower AV node, fast pathway recovers from refractory period. Right? Now what is the exact meaning of this sentence? Suppose this is AV node. So this is your slow pathway which is carrying the impulse from SA node, right? And this is fast pathway which is in refractory period, and by the end of AV node it will get out of from refractory period. So what happens, this low pathway will conduct this impulse to fast pathway as well. So this will turn this, so this is the re-entry. Also it will also give to bundle of His. What I want you to understand, initially the fast pathway was in refractory period and by the end it has recovered from the refractory period. So the impulse that is carried through the slow pathway will enter in this fast pathway and will give impulse in re-entry. There is a re-entry of impulse. So it will give this impulse to this, then to SA node, right? Also this will give impulse to bundle of His as well. So this is the basic reason, basic mechanism behind this PSVT. Let me revise you what is the premature atrial beat. Normal conduction is ongoing. There is a premature atrial beat that goes to SA node and stimulate it again before ending ongoing neuronal conduction, right? Now this SA node to bundle of His, to Purkinje fiber, to ventricles, is it following the natural pathway? Yes, it is following the natural pathway. There is no such thing that is depolarizing ventricle directly. So what will happen to QRS complex? QRS complex will be narrow. Let's see what are the ECG findings that we get in PSVT. Now there is a absent P wave. So what do you mean by absent P wave? Since the heart rate is very high and the conduction is continuously roaming in circle, right? So this conduction is not from atria. P wave, what signifies it? Atrial contraction. But here the impulse is coming from AV node due to re-entry, right? So there is absent P wave. You can say that there is a P wave because atrial contraction is there, but it is embedded in QRS complex. So that is not visible on ECG. Also you can get retrograde P wave, that means U shape. Now how do we get this? Since there is a conduction that is going in this upward direction and this will depolarizes the atria. Normally when the atria depolarizes from SA node, but what is happening here is AV node is depolarizing atria. So when SA node depolarizes atria, we get upright P wave, but when AV node depolarizes atria, we will get U, that is a retrograde P wave, and which is adjacent to QRS. Retrograde P wave adjacent to QRS complex. This is the first thing, that is absent P wave. Second is retrograde P wave. Third is narrow QRS complex, usually lesser than 100 millisecond. What about the ventricular rate? So the ventricular rate will be around 170 to 180 in beats per minute. In many books it has written 150 to 250. Okay, so these are the characteristic features of ECG in PSVT. So this is the ECG of PSVT. You can appreciate there is no P wave. The QRS complex is very short, less than 100 millisecond. What about heart rate? If you think it as a less than 2 large boxes, if you divide it less 300 divided by 2, it will be more than 150. This is the ECG of PSVT. Now what are the clinical features? So patient will present you with the palpitation, breathlessness, chest pain, syncope, dizziness. Patient can present with the shock as well. So these are the usual clinical features of PSVT. Now what is the treatment? So treatment part is very important in PSVT. The first thing is you need to understand whether this patient is presenting to you is stable or unstable. So hemodynamically stable and unstable. What do you mean by unstable? When there is a shock, when there is a chest pain, or there is a sign of ischemia, when the patient is altered, or there is any evidence of end organ damage. So this is the patient with the unstable. What about the stable? Its vitals is relatively within the normal limit. Now what is the protocol for stable patient? For stable patient, we will first start with the carotid massage. If we do the carotid massage, there is a vagal stimulation which leads to AV blockade. So there are few precautions that we have to take care before doing this carotid massage. The first one is to rule out carotid artery thrombosis or thrombophlebitis or atherosclerosis. If there is any carotid brew, then we don't do carotid massage because this will cause stroke. After massage, the emboli can go to cerebral circulation and then stroke can be there. So we don't do carotid massage in atherosclerosis or thrombus or there is any presence of a carotid brew. Also we don't do it on both sides simultaneously. So this is the carotid massage. Carotid massage is in vagal maneuver. The first one is the carotid massage. The second one is a Valsalva maneuver. How do we do this? Patient lie on flat surface, then chest is elevated, head and elevated at 45 degrees. Then we ask patient to hold his breath and strain against closed glottis. Ideally we do this for 10 to 20 seconds and we will observe the rhythm. There is something modified Valsalva maneuver. How do we do this? The position will be the same, but what we ask to do is we give him a 10 ml syringe and he will blow that syringe in such a way that it can lift the plunger for 15 seconds at least. Then what we will do? We will make bed flat and passively elevate his or her legs at 45 and then we will lower it. This is for 15 seconds and after lowering it, it is 45 seconds. These are the vagal maneuvers that we can do in PSVT. Now what is the pharmacological methods? When this vagal maneuvers fail, we do pharmacological methods to control PSVT. The first one is adenosine. What it does is it transiently block AV node. Why do we need the transient block AV node? Because it is started due to premature atrial beat. This started the AV node impulse. So this cycle continues and it goes on, and it is started by premature atrial bleed. So as soon as we block AV conduction for a while, then the whole normal conduction restarts. How do we give the adenosine? We give 6 mg. If not recovered, we give 12 mg. Then again we can give 12 mg second time. And how do we give it? So adenosine is having very short half life, around 10 seconds. So what do we do is we get a IV access of large vein like the brachial one, and we give this injection 6 mg adenosine on that vein. Then we will raise that arm while pushing flush. So this is important. This question can be asked in NEET PG as well, that how do we give adenosine? They might ask you about the short half life, whether it is short or long. So please remember this method. What about the unstable patient? So in arrhythmias, always remember, if there is a patient with the unstable hemodynamics and patient is having arrhythmia, the treatment of choice is always the shock. Now in this case it's a synchronized shock. How do we give this synchronized shock? So defibrillator, identify R wave in ECG monitor and it delivers shock at R wave, and this will restart heart. What is the dose? We can give 50 to 100 joules, which can be increased to 150 and 200 joules if not recovered. So this is the PSVT. I hope you understand it well. Next is AVRT. AVRT, that is Atrioventricular Re-entrant Tachycardia. What is AVRT? AVRT is a type of PSVT. It's a type of PSVT. Here also there is a macro re-entry circuit involving AV node plus accessory pathway. Now what is the connection between AVRT and WPW syndrome? AVRT and WPW syndrome. You must have heard about this WPW more frequently with the AVRT, but what exactly it means is WPW is a structural heart disease. Structural heart disease, and AVRT is a arrhythmia that we get in WPW syndrome. Okay, in order to get AVRT, we require two conditions. The first one is there should be two pathways. One is AV node and one is accessory pathway, and the second one is unidirectional block plus re-entry. Now what is this unidirectional block plus re-entry? We will study it in detail. So what happens in the WPW syndrome is that there is a accessory pathway, that is Kent, bundle of Kent. How this bundle of Kent is there in heart? It connects atria to ventricle through accessory pathway, right? So let's draw a diagram. Suppose this is SA node, this is AV node, this is bundle of His, and then there is a ventricle, right? So what we get in WPW syndrome is there is a accessory pathway that is directly connecting to the ventricle, right? So whenever there is an impulse generated by SA node, it will depolarize two things. The first one is AV node and the second one is this pathway, that is accessory one. What is the characteristic feature of this bundle of Kent? This bundle of Kent is longer refractory period. Since there is no AV delay, it has a faster conduction, right? So whenever the SA node generate impulse, it will travel to AV node and simultaneously it also gives to bundle of Kent. By the time it reaches to bundle of His and it gives impulse to ventricle to depolarize, there is already a part of ventricles that is being depolarized by this bundle of Kent, right? So by the time impulse reaches to ventricle, there are parts of ventricle which already depolarized by accessory pathway. Why? Because there is a faster conduction by bundle of kind. Okay, so what do we get on ECG? It's a P wave followed by there is a delta wave and T wave. There is no Q wave. Why? Because at the time of septal depolarization, part of ventricle is being depolarized by bundle of Kent. So at the time of septal depolarization, this accessory pathway is depolarizing this part of ventricle. That's why the Q wave is absent in bundle of Kent. This is the normal pathology when there is a WPW syndrome present in a particular heart. Now, what is the antidromic AVRT and what is orthodromic AVRT? Let's assume again this is SA node, this is AV node, and this is ventricles, right? There is a accessory pathway that is directly connecting to ventricles, and this is called bundle of Kent, right? Now what happens in AVRT? There is a foci which generate impulse. So foci generate impulse which is a premature impulse. Premature impulse, right? So due to this premature impulse generation, so this premature impulse when it reaches to SA node, it will generate impulse to both AV node and accessory pathway, right? But when there is a premature impulse, one of this pathway is in refractory period. See, whenever there is a normal conduction, both the pathway is out of refractory period. But whenever there is a premature impulse that reaches to SA node and impulse reaches to AV and accessory pathway, one of the pathway is in refractory period. Why? Because it is a fast conduction but long refractory period compared to AV node. So most of the time this accessory pathway remains in refractory period when the impulse reaches to it. So the conduction will follow this AV node, right? Then from AV node to bundle of His, then bundle of His to ventricles. Now what happens in this condition is, by the time the part of ventricle is being depolarized, this accessory pathway get out of refractory period. So by the time when ventricle is being depolarized, this refractory period of accessory pathway is diminished. So the conduction goes from ventricles to accessory pathway. Let's understand this on this image. So impulse is generated, it has gone to SA node. Due to this impulse, that is a premature one, it travels to AV node because this accessory pathway has a long refractory period and it is in refractory period, right? So it goes to AV node, then AV node to bundle of His, and then bundle of His to ventricles. And by the time it reaches to ventricles, this becomes ready to depolarize. That means it is out of refractory period, and so that it will flow the conduction through this direction, and again this will depolarize this pathway. So there is a formation of loop. in this direction. ECG finding in this is short PR interval, narrow QRS complex, retrograde P wave, that is it comes after QRS complex. Why? Because after depolarization of ventricles, it goes through this pathway and it will depolarize atria. So we get P wave after QRS complex. Now this is called orthodromic AVRT, right? So in orthodromic AVRT, impulse follows through AV node, then to ventricle, and then to accessory pathway, and again to atria, right? So this is the flow of pathway in orthodromic AVRT. Now what happens in antidromic? Let's suppose when we said that accessory pathway was in refractory period, so the impulse was passed through AV node, right? Now AV node is in refractory period, so impulse will follow through accessory pathway, right? So SA node, AV node, bundle of his ventricles, and here is the accessory bundle of kin. So what I said, this AV node is in refractory period, so impulse will flow through accessory pathway and it will depolarize ventricle first. So ventricular depolarization will occur first. Now what type of depolarization it will be intermyocytic. Intermyocytic conduction. So what we will get? We will get broad QRS complex, right? And then from ventricles it will conduct impulse in this upward direction and AV, and then again through this channel. Flow of this current is in antidromic pathway. So this is antidromic pathway. Now why do we need to study this antidromic and orthodromic? What is the main purpose of this studying this both AVRTs? Now just imagine we are dealing with the antidromic AVRT. Now what you did, you saw the ECG and you said that this is a AVRT, I will give him a adenosine. So you said that, sir, it's a ECG of AVRT and it has a WPW syndrome, so I am going to give him the adenosine so that we will terminate this AV nodal conduction. So adenosine will block AV node. Now what will happen after blocking AV node in this case? If you block AV node in this case, this pathway will get encouraged, right? So there is a continuous ventricular tachycardia due to ventricular depolarization, which leads to ventricular tachycardia, and this is a life threatening. So we don't give adenosine or any AV nodal blockage in the antidromic AVRT. So this is very important to understand. Whenever there is a ECG showing the broad QRS complex, you need to understand when to stop to give AV nodal blockage, because if you give the AV nodal blockage, the accessory pathway will be encouraged to carry impulse, right? So we don't give AV blockage here. So in question you could be asked, like when the adenosine is not given, they will put the options like orthodromic, antidromic, WPW syndrome and all those stuff, and you have to make it correct. So what is the treatment option for orthodromic? we will treat it as a PSVT. All the stuff for stable and unstable patients, we treat it as a PSVT. And for antidromic, we don't use adenosine or vagal manure, right? So what is the drug of choice for AVRT? We can use amiodarone, we can use procainamide. So these are the drug of choice that we can use in antidromic AVRT.